To present Dr. Christina Howard. Let you take off.
All right, thank you. So it was very open, but I decided to talk on really the two main topics that we've put most of our work in over the past year, and some of where we're going to be moving into the future. So I'm Christina Howard. I am a child abuse pediatrician. I started the Division of Pediatric Forensic Medicine at the University of Kentucky back in 2015. And I've also taken on the role as the consultant for the Department of Public Health in child fatality review and pediatric injury prevention. And so I do participate in all of the CFR, the child fatality review team meetings that happen across the state, which can keep you pretty busy, but I do still try to attend most of those. And so this is a little bit cut off, but I don't know if a lot of you guys hopefully are familiar with your child fatality review teams that are done at a local level. And so what that does is it really is a child death review that equips communities to improve safety and prevent future fatalities through a multidisciplinary approach. It is not to point fingers at what was done wrong when a child dies. It's really to look at how can we improve it and prevent these deaths from happening in the future. And Kentucky has come a long way. As you can see, in 2017, there was only 51 active CFR teams. Now there are over 106. There are a couple counties that do not have a CFR team, but they also don't have any child deaths to review. There are a couple of counties that do have deaths to review, but no CFR team. It is typically a coroner-driven CFR team. You have to have the coroner involved with it or a deputy coroner in order to run those meetings. And then you do get support from the Department of Public Health. They have nurses that help the local teams pull together the community partners. We all attend the local meetings to kind of help with that, and they collect all the data and enter it into the registry nationally. And so that's who keeps all of our data across the state of Kentucky. And so I think I started this role in either 2018 or 19. Shortly after coming into it, I was sitting down with the CFR team because there was an opportunity called the Child Safety Learning Collaborative. And so this is a collaborative that is a national collaborative that pulls together states on certain focuses so that we can collaborate, use evidence-based policies and prevention and whatnot. And so the main topic areas that the CSLC really wanted to focus on at that cohort, so this was cohort 2, was bullying prevention, motor vehicle traffic safety, sudden unexplained infant death, and then suicide and self-harm prevention. And so as a team, we did decide to join the collaborative that was involved with suicide and self-harm prevention. And so we'll talk kind of about where we were at that time when we made that decision and where we are moving forward, because I think we all know that mental health, we're in a mental health crisis right now. And so this work is continuing to be important. But when we decided to join that, suicide was the second leading cause of death for youth and young adults in Kentucky. 15% of Kentucky high school students reported having seriously considered suicide within the past 12-month period. And there are different regions that, honestly, even in Fayette County, different zip codes where that can change just from going to zip code to zip code. Another thing that has been pointed out is your life expectancy in the Fayette County actually changes from just going from one zip code to the next. And so this does change depending on where you live. And then the other thing that really got, honestly, what started my work with the CFR teams was that I was working on the hospital side, reviewing our deaths in the hospital. And we really were traumatized because of the number of young children that were getting younger and younger that were dying by suicide. And so that's where I really started to reach out to the Department of Public Health, because I was like, what is being done about this? Because we know we had an 8-year-old die by suicide recently. And so it is happening at a younger and younger age. However, we do know that suicide can be preventable. And so we need to be able to understand how to respond and help people that are in that situation. And then you can look at the data in 2019 about the middle school, and those that had tried to kill themselves. It had increased by 3% in 2 years. And so this is just some of the headlines that were coming up at that time. And so you can see the coroner alarmed by 5 suicides of kids 14 and under in a single year in Fayette County. And so that's really what triggered some of this. As a child abuse pediatrician, I would go to a lot of these child fatality reviews. And when we review that, we review what kind of led up to that decision to take that child's life. And so many of those children had so much adversity growing up that really impacted me as a child abuse pediatrician. We had been doing a lot of work on identifying child maltreatment. We can't miss abuse. But then it's what comes after once you find a child that's been in an environment where they have been a victim of child maltreatment. And I know you have a talk from the Center on Trauma, and that there's somebody that we work with pretty regularly for our victims of child maltreatment. And so I'm not going to pretend to be the expert on that piece because they are important partners. But it comes up, I think, has everybody heard of the adverse childhood experience studies? And so when we were examining, I had a 5-month-old child that already had 6 ACEs. And at that point, I was like, it should not determine this child's life expectancy is 20 years shorter than my child's life right now. And that was not fair to that infant that's 5 months old, that their life expectancy is 20 years shorter. And so, yes, Kentucky children have a high number of ACEs when you compare them to national data. 30% of Kentucky children have more than 2 ACEs. That is more than the national data. 1 in 5 have more than 2 by the age of 5. And then Kentucky children with ACE scores greater than 3 is one of the highest rates in the country. And so this is where you see what the ACE score is in regards to attempting suicide during adolescence. And so that 5-month-old or 6-month-old or 5-month-old that had 6 ACEs has a 8% will have attempted suicide during adolescence. And then you can start to see here also the number of attempts of suicide based on grade level. And you see the sharp increase in those in 6th grade that had attempted suicide in the prior year. And then those that had thought about attempting suicide. And so you can also continue to see there's an increase in all of the grades. However, the 6th grade has the most dramatic increase. And then self-harm. Let me see if I can. I think I can just close that off. Sorry. So suicide attempt again in the past year is this one. And so when we started to kind of think about what was our approach that we wanted to do as a state, Beck Whipple, I think he's part of this program. He's usually present. I don't know if I didn't see if he was online or not, but he was part of our team in this, and he actually was the person that brought up the zero suicide work. And so when he started to talk about that, we looked at kind of what the zero suicide framework is. And yes, it could be overwhelming when you're really starting from scratch, but he felt that this was very important for our state to do moving forward. And so that's when we made the commitment as our CSLC team that we were going to try to implement zero suicide. And so that is kind of where a lot of the work started. And so zero suicide, it's really a quality improvement framework. And it uses each of these different categories. So you have to have the lead, you have to train your employees, you have to identify those that are at risk, know how to engage those, treat them, transition, and then improve are the 7 categories of zero suicide. And so it is all evidence-based, and they actually have like online how you can, each category, your steps that you need to do to improve it. Being at UK did sign on to join this collaborative, and we did our first initial assessment of our program at UK, the whole Department of Pediatrics, and on a scale of 0 to 4, we scored about 0 to 1 on every single category. And that's terrifying to me because UK is relied on by a lot of the community for any pediatric services, especially when you consider subspecialty services. And so to start it, we did host a Zero Suicide Academy. Department of Behavioral Health did pay for that. And what we wanted to do was really to have an academy that brought together the community, because it's not just UK that needs to work at preventing suicide, but we also need to have our community partners. And so we utilize the community mental health centers to also join the meeting, so that UK could work with New Vista in order to have a community response to prevention of suicide. And so these were the teams that joined the Zero Suicide Academy. So you can see some from Central Kentucky, Owensboro areas, the 6 and 8 down at the corner, but we had a really diverse geographical region that was represented at the Zero Suicide Academy. And so all community mental health centers in Kentucky are utilizing zero suicide. And then the first stage had 2 healthcare agencies, so the University of Kentucky, and then Owensboro Regional Health was also signed on to do zero suicide. However, it's not a 1-year thing, and it takes a lot of resources to do that. And so if anybody works at UK, it takes about 10 years to do a 1-year project, because there's a lot that you have to go through to do it. So what we first started off with was like, okay, well, we can at least train. We can try to get everybody trained in QPR, which is like BLS of mental health. And so we did kind of start to do the outreach as far as training goes across the state, but specifically at UK as well. And you can see from June to March of that year, we trained over 1,200 people in QPR. I think one of the most common questions I get asked is like, is this just professional? So we'll get our doctors to do this or our nurses. It's like, no, this is our front office people need to do this. Every single person that works in that environment needs to be trained in QPR. I think Seattle actually did some research that felt that one person in every single family should have QPR training. And so it's really beneficial for every single person. And currently to date, we have trained all 556 ambulatory staff and faculty at UK. So yes, physicians are sitting in there with frontline, they're all getting the training. And so we have trained 556 staff at UK ambulatory. Our next hurdle is inpatient. Inpatient is about 1,600 faculty and staff. And so it's a lot more daunting, but that's our next step. We've also started doing some at the elementary school levels, because as we said, kids are getting younger. I think one of the things that we've noticed is that we don't do a lot in the elementary school age as far as screening. I think that is changing as we're seeing deaths by suicide happening at a younger age. But we have started some QPR in Jessamine County. I think there was somebody here from Jessamine County earlier, so in the back row. So we have started some QPR at a couple of those local elementary schools. We have one in Fayette County we're getting ready to do. And then the other thing I'm real excited about is that we also have had the UK athletic department sign on for QPR training. And so we're going to be training the coaches and assistant coaches and the athletic director and everything at UK in QPR. But that makes me really excited, because that also means that it was kind of making a partnership with them to talk about mental health on their athletes, but also how can they're huge role models for the state of Kentucky. If anybody in Kentucky thinks of Kentucky, they think of sports, right? And so it's a really huge platform for prevention of suicide. And then additionally, the Department of Pediatrics has now formed a division that's focused specifically on mental health in the pediatric population. And so that amount of resource is really an incredible dedication at that type of level. And we are getting ready to hire a person that's going to really be the lead of zero suicide, because it's a lot of work. I'm already very busy, and it was honestly overwhelming for me to really change this across the whole enterprise. And so we are hiring a dedicated person to really start to take on those next 7 steps. But we do have the leadership support, and I think that speaks hugely for this. CSLC did just get additional grant funding to start on cohort 3. And so we are continuing with our zero suicide work as cohort 3. We're going to continue to do QPR training with the focus that we really would like to kind of get to the CFR teams I think one of the things we didn't talk about on that last talk that we get a lot of feedback on a CFR perspective is really the secondary burnout that is associated with natural disasters or reviewing any child's death. There's a lot of secondary trauma when first responders respond to that. And so we're really trying to get into the community from a CFR perspective so that QPR can happen in those settings as well. We hope to have additional hospital systems come on to zero suicide. We've learned a lot here at UK, and one of the nice things is that a large percentage of our hospitals utilize the same electronic medical record system. And so that can be shared across the state as far as the screening protocols that go into it and what the response is to those screeners. And so we would love to have some additional healthcare systems sign on to zero suicide as well so that we can really implement this statewide. And then we're going to also go the next step too. One of the things we realized is that for our mental health providers at UK, there's no standard training that is offered. Typically, it is the provider is responsible for their own continuing education, and they have to seek that out themselves. And so we've now kind of streamlined what type of mental health training, what type of training our mental health providers are getting. Additionally, we were asked to take on another project for cohort 3. And so that was the bullying prevention. So we are going to now have 2 focuses. And some of that was because there is some overlap in bullying prevention and prevention of suicide. And so we are going to start that next. And so if I'm reaching out to any of you guys to help us with this, or if you are interested, you can reach out to us. We'd be more than happy to have help in that. I am actually going to now switch topics a little bit to talk about the second line of work that I've really been working a lot on over the past year, and that is children that have been exposed to substances, specifically pediatric ingestions. And so we'll talk a little bit about drug endangered children and some resources that are available to all of you all if you would like to utilize them. And so a lot of our work over the past year and the year prior was supported by the OD2A grant with KIPRIC. And so I, as well as KIPRIC, and then Face It, the Face It movement with KYA, COSARE for Kids, Face It movement with KYA, had partnered to really try to get the word out on pediatric ingestions. So a drug endangered child is a child who live in a dangerous drug environment because their parents or caregivers either manufacture, cultivate, distribute, and or abuse illegal substances. I am honestly very thankful. A lot of the manufacturing has kind of moved to Mexico because I remember through my training, we used to get a lot of injuries from meth lab explosions or children ingesting substances that were being used to make meth. And I've not seen that, knock on wood, in several years, because a lot of that manufacturing has moved to Mexico, and we now import that final product is being crossed across the borders. So I don't see as many manufacturer injuries as we did in the past, but we are still seeing a lot of substances in the home and fatal substances in the home. Approximately 9 million children across the country live with at least one parent who has substance use disorder. So more than 12% of the children in the US, and 1 in 5 live in a home where adults use drugs or misuse alcohol. Because 40.3 million Americans had a substance use disorder in 2020. I also sat on the Maternal Fatality Review Board, where we reviewed the deaths of mothers who had died within a year of giving birth. And Kentucky has an incredibly high rate of deaths because of overdoses within that first year after having a child. But one of the things that we see when we review those is that a lot of these moms, their substance use started at the age of 12. I have a daughter that is now 12, and that terrifies me to think that that is when they started with their path down substance use. And so, yes, 12 and older is an important time frame. And then, of course, one of the most deadly, when we talk about deaths, overdose deaths, most of those involve fentanyl, I think is what we are really seeing right now. Fentanyl is being cut into absolutely everything. We honestly just had we did have a death in Western Kentucky of a child who was vaping marijuana in the bathroom and didn't realize that the marijuana was laced with fentanyl. And so he did die as a result of that. And so again, one of the things about marijuana is, yes, it's now legal if you have that note from your physician, but I think we still need to work on regulating the marijuana that's out there, because you can have a note, but you're still responsible for finding that marijuana. And so what we are getting on the streets is really not safe a lot of times. And so we need, as a state, to be able to still make sure that we regulate it to make sure that it's safe if we're going down that legalization route. And so if we look locally at the state of Kentucky, Kiprick had actually been trending the deaths by overdose in Kentucky. And we had been making some improvement prior to 2020 as far as our deaths due to overdose. However, COVID hit, and we did see an increase in overdose deaths. So in 2021, there were over 2,000 overdose deaths in Kentucky, which is a 14.5% increase from 2020. So it's been a huge increase. I think it negated any of the progress we had made prior to COVID. And again, opiate was involved with 90% of those deaths, and typically it was fentanyl. And where it's happening. And so, of course, you guys can see that Eastern Kentucky, the Appalachia area, is where you're seeing a large percentage of those overdose deaths, as well as some of the larger cities as well. But Western Kentucky is having a huge issue. So why is that important to our children? Yes, we talked about the adverse childhood experiences. So this is an adverse childhood experience for all those kids in Kentucky who have substance use in the home. That's an adverse childhood experience. And we know that that's related to the poor mental and physical health outcomes into adulthood. Neonatal abstinence syndrome, so kids that are born addicted to drugs. I think we are just now really starting to see some of the long-term impact that has as these children age. But we know that there's growth, developmental, and neurobehavioral outcomes associated with that. There are also children are 4 times more likely to experience neglect. And then children are 3 times more likely to experience physical, sexual, or emotional abuse. And then we have the morbidity or mortality related to just the exposure of an ingestion of a drug. And so in Kentucky actually has now the highest rate in the country of co-occurring child maltreatment and substance use disorder. It was involved in over 50% of substantiated cases of child maltreatment in the state of Kentucky. So we are almost twice the national average of that. The other thing that we're the highest in is intimate partner violence. We also have the highest rate in the country of co-occurring intimate partner violence and child maltreatment. Again, the most likely form is that of neglect. And I did recently have a friend ask me, in child maltreatment, THC, that makes people just kind of chill. So it decreases child maltreatment, doesn't it? And my response was, they might not you might not see as much physical abuse. However, unfortunately, I see a lot of neglect when that happens. I've seen parents not take a child to the ER and seized for hours and ultimately died because of THC. And THC is dangerous for children. I have had kids in the PICU because of THC and Delta 8, which is another substance that we can talk about a little bit as well. But the other thing we know is that when there's substances in the home, it's associated with a high number of physical abuse, but it's a higher percentage of our severe physical abuse. So our fatalities and near fatalities, you have an even higher number of parents that are using substances in the home. So when it's there, it's not only increasing the abuse, but we're seeing more severe abuse happening. And so, again, over 50% of all fatalities and near fatalities. And so now that we know that substance use disorder is a problem in our state, I think that having that conversation about having these medicines in the home that help to treat substance use disorder, because I think we are all advocates that when you have a substance use disorder, they need to be treated. So I'm very supportive of medically assisted therapy. However, one of the unintended consequences of that is that it's also bringing those medications into a home. And I don't know how many caregivers I've seen that was like, well, I put my Suboxone in my pocket, and when I pulled it out, I must have dropped one of them or something on the ground, and a child picked it up, and that's how it happened. Like, it's very lax with how people handle these medications that they're being prescribed. And so there's a lot of opportunity for education to caregivers about the dangers of this. And so as the prescription has increased, ED visits and hospitalizations for ingestions by children has also increased. And so we know that there's a strong association of increasing prescriptions for adults, and that increases the number of pediatric ingestions. And it's the association of adult use of prescribed opiates and pediatric ingestions is twice as strong as for other prescribed medicines. So like high blood pressure medicines, those types of things. And so not only is it happening as much, but they are potentially fatal medications that the kids are ingesting. And then accidental ingestions of opiates was most likely to suffer a severe clinical effect and be admitted to a medical unit. So the kids that are getting Suboxone are being intubated in the PICU because they are not breathing. We have them on Narcan drips. We had a child that ingested a fentanyl patch. And so that is a long, prolonged exposure. So those kids are on fentanyl drips in the PICU. I have seen severe anoxic brain injury, so a lack of oxygen to the brain in children that have ingested these medications and have very poor neurological outcomes as well. So in 2020 and 2021, pediatric overdose ingestions actually became the second leading cause of the near fatalities that our external review panel reviews, and it actually surpassed abusive head trauma. And so most people in here, I think, are aware that in 2007, Kentucky led the nation in fatalities due to child maltreatment. And so since that time frame, they implemented the required abusive head trauma training for multiple different disciplines. And we actually went from first in the country to 44th in the country. So there has been I think that is a huge success when you talk about fatalities. Over the past couple of years, there's actually been a bump back up as far as the number that we're seeing. And I think that's because of pediatric ingestions, not necessarily because of abusive head trauma. And so these are the numbers from 2020. And I don't think I can get that off the top of it, but you can see here, I think that there was 4 deaths due to overdose. And you can kind of see that there was a large number of near fatalities in 2020. And then in 2021, that actually went up to have 7 deaths due to ingestion. So it almost doubled within a year of the number of deaths. It used to be, we would see a lot of these ingestions, but they wouldn't result in death because of the availability of Narcan to reverse the action of it. But unfortunately, we are continuing to see the death a lot of times because of delayed care, because they are being delayed. And then, I kind of have mixed feelings. I think Narcan is very important to be available, but I think we've also seen parents try to administer Narcan to their child themselves instead of seeking care. And so that is a concern that I have with Narcan, is that I definitely don't want parents to use that instead of seeking care for these children. And so that is one of my concerns with Narcan. But I know that we still need to prevent deaths. And so I think that it's still important to have out there. But And this is a chart since 2018 of the types of fatalities and near fatalities that we were reviewing. And you can see the light blue line is those due to ingestion. And so again, that's had that drastic increase in the numbers that we have been seeing. When we talk about statistics from the external panel, yes, we are talking about the most serious ingestions. These are the ones that have resulted in a child nearly dying or dying. And so the number one substance that we see that leads to a child in that condition is going to be some type of opiate like fentanyl, Suboxone, those types of things are going to be the most dangerous because those are the most fatal. When you look at poison control data, actually the biggest increase in calls to poison control was due to melatonin. And so that has increased. What was it, Steve? Was that almost 3,000% in number of calls to poison control due to melatonin? And so that is, again, still something that the kids are getting access to. As far as ingestions in general, these are all ingestions that pediatric emergency departments see. Nearly 60,000 end up in the ER every year due to an accidental ingestion. Ages 0 to 4 were at the greatest risk of death, and the 61% of poisoning deaths were attributed to medication and or illegal drugs. And so almost every minute of every day, there is a call to poison control because a child has ingested something. Every single minute. So since I've been up here, 30 children have been called poison control because they've ingested something. So we are not protecting our children. We are not making safe environments for our children right now. And I admit it's a struggle. How many people have Tylenol in their purse? Tylenol is an incredibly dangerous substance to children if they get too much of it. And so it's very challenging because ease of access is important. When I have a headache, I need something, right? So the purse is going to be the easiest place to do that. There have been a lot of efforts made over the past 50 to 60 years in prevention of ingestions in the pediatric population. I think one of the biggest impacts was when they started to mandate child-resistant packaging to pharmacies. That did make a huge improvement in the number of ingestions. However, again, we kind of see that saturated to where we're still just getting too big of a number. And then in 2008, there was the Protect initiative from the CDC to really help to ensure safe environments. However, it's still a serious public health concern when we are now seeing more of that than abusive head trauma. And so one of the things that has been interesting when you look at the data from poison control and pediatric ingestions and with their caregiver in substance abuse disorder treatment is that they were actually found significantly lower rate of calls that when a person was prescribed strips versus the unit dose packaging. And so tablets, those types of, the tablets had a higher number. So kids were ingesting tablets, not as much the strips. Other factors contributing, I think that one of the things that we tend to see a lot is this, as they start to wean down doses, they actually instruct families to either cut pills or cut strips. So you're having little pieces that are kind of being left around. And so to get from an 8 milligram tablet to 6, you cut it in half and then in half again. So you have a quarter of the pill kind of hanging out up here. And that's very easy to lose and lose track of. And so those types of things, you can see the higher rate of kids getting exposed to that. And so we still need to increase counseling of patients on safe storage. Additionally, when you analyze the cases, and this is probably a little bit out of order, I need to move this up some. When you analyze the cases to poison control involving substances, 86% of those families were in MAT treatment. So they were in medically assisted therapy treatment. And so I think this is a very valuable resource in our state of Kentucky in order to provide education to patients and families about safe medication storage. And so the other thing is that small children mistake these pills for candy. I think that the taste for Suboxone is more of a sweet taste, and so it doesn't taste as bad. But then we also see it a lot with our Delta 8 products, because Delta 8 is currently legal in the state of Kentucky. Has anybody seen them at the gas station? They are gummy bears, gummy worms, brownies, cookies. That's what our Delta 8 is looking like at the gas station. Bags of Skittles can have with Delta 8 in them. And so I've had kids that have eaten 5 Delta 8 gummies and been in the PICU. Kids aren't going to stop at just one gummy either. They're not going to stop with one brownie, with one bite of a brownie. And so that's, I think, one of the potential hazards we need to be careful of. And a majority of these exposures happen in the home. And so the external panel did make recommendations that families that are receiving treatment need to be educated on safe storage of that treatment. And so there needs to be, providers need to talk with their patients about ensuring if there's children in the home, where these should be stored and how they should be stored. The other thing that we see a lot is also that parents will go from that they travel a lot, they stay over at friends' places a lot, people come in and stay with them a lot in certain environments, and when they go and sleep over, they're putting stuff in like a Ziploc bag or a sandwich bag or something, and that's not a safe way to store medications. So encouraging caregivers to get safer travel packaging from the pharmacy, and also understanding that child-resistant packaging, while it's improved, it's still not child-resistant or child-proof. And so I think we've seen videos where like that 2-year-old can get into that medication bottle that's child-resistant. And so making sure that just being comfortable saying, oh, that's child-resistant, they won't be able to get into that. No, kids are pretty sneaky with what they can do. And then one of the things, one study did find that only 1% of families who had children with an ingestion kept medication in a locked container. And so at our hospital, we do provide medication lock bags to every family that comes in after a child has ingested a substance, because every single family that we interview does not have that already. And so they're very thankful to get those. I think that I skipped that. Okay. One of the things that parents think is that as long as the child is being watched, the medications are safe. But life happens. I think everybody knows at some point a caregiver has to go to the bathroom or wash their hands or look away for a split second at something. And that's all the opportunity a child may need to get access to medications. What we perceive as needed supervision is really less than what is needed for supervision. And that we typically will underestimate what a child is able to do. And so we will say, well, it's up in that cabinet, they can't get to that. I always bring out a similar story in a child that came in because he had a real big laceration on their forehead after a hammer fell on his face. And the parents were like, well, the hammer was on top of the fridge. I don't know how we got to it. But all the kid had to do was move a chair next to the fridge, and they were able to climb onto the counter and then up onto the fridge, and that hammer fell right on his head. And so at my son was climbing chairs between 1 and 2 years of age, and that's a very young age. So they start climbing pretty young. Again, caregivers can just be distracted for a few seconds, and this can happen. I'm going to kind of go through this. And so what are some of the recommendations? So we do think that there needs to be counseling of caregivers at primary care offices to MOUD providers. It needs to happen across the board. When appropriate, use single wrapped film strips in the MOUT providers. And then educating them about how things may look and appear good and taste good to children, and so they may not stop it. This is just some tips on how to have some of those conversations, but I did want to talk about, so this was one of the things that we worked on over the past year is this medication safety storage in the home. So we did a media campaign that started August of, I think 2022 is when we did our kickoff. And then we did a lot of PSAs, but the main thing is we bought multiple medication lock bags. When I say multiple, I think my staff hates me right now because we've been stuffing medication bags for about 1.5 years at all of our free time, including our kids. And so we have been able to develop a training that is now on CE Central, free of charge to all MOUT providers across the state, about how to talk with families about safe medication storage. That has been done by over 400 MOUT providers across the state. And once they complete that training, we also distributed medication lock bags to them. So we've distributed over 8,500 medication lock bags to that population. We did expand to also include hands in that distribution. So some of that does include hands and our needle exchange programs as well. And so that grant did finish. And I was going to say, I think, Steve, you guys are going to talk a little bit about your upcoming program as well. We do still have about 4,000 bags left. And so we're working with Steve. He'll talk next about if you want to distribute those. We don't have restrictions anymore on who they can be sent to. And so if you have an organization that would like to be able to be part of distribution of this, the new email address is, do you have it on yours? Do you have it written down on yours? Okay. It's childhomesafety@ky.gov. And so I think that Steve will provide that to you all, and we're going to work together to kind of get these medication lock bags out to the rest of the state also. And then as part of that, we did do a kind of a media campaign through Face It. So CoSARE for Kids Face It movement, where we'd had 8 PSAs that were developed. We also did ads on pharmaceutical bags through Kroger. So we made multiple, on the printout, you know how you get the ads on your printout when you go to the pharmacy. So we put some safe storage messaging on pharmaceutical bags, did digital ads across multiple channels and news outlets. We disseminated the one pager that you saw on this previous page. This was a one pager that was developed. We did that and some magnets as well. We have a web page that is on Face It's website. We promoted safe medication storage throughout all of the listservs and engaged partners across the state, including the Attorney General's office, because they have also been aware of these increases. And with that, through all of our PSAs, those have been viewed over 250,000 times. We put that ad on 96,000 pharmacy bags that will be going out to certain regions in the state. Had over 550,000 impressions through paid digital ads. But ultimately, through all of this, we were able to reach 1.36 million Kentuckians with this messaging, which I think is a pretty good outreach when you're talking about a little over 3 million adults in the state. So we still do have some work left to be done. And so if you guys are interested in helping to get this word out, that would be very helpful. And I was going to actually show the easiest way to find this. And so if you go to faceatabuse.org and you go up here to resources, there's actually a lot of amazing resources on this webpage that you can print out. And so one of the resources that we did previously during COVID was the Connect. And so how do you build resiliency through family connections? So that is on there, but here's a category for safe medication storage. And it includes the one pager you can click on, and you can get that, and you can either print it yourself, or if you want to reach out to KYA, they could also help to print that for you. So let me close that one. And then further below, there are resources. And so this is like an example of one of our PSAs, and I don't know if you can, I don't think that you guys can hear that volume, but we had multiple different people talk about various tips on how to keep medication safe in the home. And so this was a grandmother who had kids in her environment. We also had one of our toxicologists at UK did a PSA. And then Jennifer Hancock also did one for us. And then I always tell everybody, one of the things we give in our medication lock bags is a magnet with the poison control number on it, that everybody should have the number for poison control at all times. And so we do still like to get those magnets. If you guys want them, like we requested them and they sent us boxes and boxes of them. And so magnets are another great thing to be able to put in this. I am going to, I think as far as next steps go, outside of the zero suicide stuff that we talked about next, again, partnering with anybody to get more medication lock bags out there is also very important. And then our next things that we're going to try to also do with the bullying, but also we're trying to implement some screening across the state called SEEK, so Safe Environment for Every Kid. We are starting with a pilot project in one of our practices at the hospital, but really wanted to get it out community-wide, including like the extension offices, so that we can really connect families to resources. And so that's what SEEK is one, do you have the number for poison control? And if the answer is no, we can give that to you. We can get magnets for you. And so SEEK is a questionnaire that goes through 10 to 11 questions. It's one page, but it also gives you, like, if this person responded this way, here's what you need to do. Here's how you need to have conversations with them. And I'm very huge on, I think, when I was taught through residency, I was always taught, like, go in and talk with them about smoking and the dangers of it and the newborn infant, those types of things, what safe sleep is, tell them how their baby needs to sleep. So here I am as a fresh resident, I'm going in, well, the safest place for your baby to sleep is on its back in the crib. You should not smoke around your child. You should not do this, this, and this. Nobody ever talked to me about motivational interviewing and really how you should talk to families about wanting to make a change in their lives for the safe and well-being of the child and their family. And so I think ensuring it and trying to come have those conversations with families is very important, and not just to preach at families, which I feel like is what they get a lot of. And so SEEK will help to do that. So that's kind of where we're moving towards. So I am going to leave any time for questions, or if anybody wants to add any additional any additional information to this conversation, please do. Yes.
Go back over just a little bit on how naloxone, how that's tied in with the children. And I know you said you're working with all the harm reduction folks and stuff like that. Is that so? If I heard you right, the problem is the parents giving the naloxone and then not seeking pain.
Correct.
But children, if they look like they're going out and they get naloxone, that's not what the problem is, or is it? Or
yeah. So my biggest concern with that is one, naloxone is a life-saving medication. So I think that it is important for our kids to get it. However, there's also a lot of fear that's associated with parents having a child that's ingested a substance. So a lot of times what they don't want their child to be harmed by any, I don't think their intent is to harm their child, but they don't want to get caught. So they try to give the child Narcan to fix the solution. And then they don't want anybody else to know that happened. And so that's where it concerns me, is that they're not seeking care for that. And so, and then there's also that knowledge, like one dose of Narcan very rarely fixes the solution. A lot of times in pediatrics, since they're made differently, they're not just small adults, right? They don't metabolize drugs the same. They frequently will need more than one dose of Narcan. And so they have to be monitored overnight in most of these situations to see if they need additional dosing. Most homes aren't equipped to do that monitoring. Mine's not. And so what we don't want is for kids to get the Narcan and then that tried to be hidden from us. We did have a fatality that was the case. And so that's a concern.
Other ingestions that might be the wrong thing.
Most of them has been because they knew that it was some type of like opioid. But I think we need to get Narcan out there. I kind of have mixed feelings about distributing it to like in our peds ERs to parents. Like, I don't want to send my ingestions home with Narcan and say, well, this is how you use it next time. But I do think Narcan is getting out there, but they need to know that care needs to be sought if Narcan is administered. Absolutely. Yeah, any other questions? Thank you, guys. I hope this was beneficial. And again, reach out to Steve or I if there's any questions or if you want medication lock bags. And I think, Steve, are you talking next? All right.